Thank you so much, Velma. That was very stimulating, and I'm just so excited already by the comments and the thoughts. I think we're going to have a great time today thinking about these things. In particular, the elephant in the room. I think it's interesting. She's saying we must embrace that elephant. However, elephant's too big, right? So we can't embrace it alone. We have to embrace it together and figure this out. So thank you for that. It was wonderful. I have the pleasure of getting started with our panels today and introducing our first moderator. The first panel is Building Community Capacity, Choosing and Implementing Evidence-Based Programs with Fidelity. So we're going to dive right in. And it is wonderful to introduce Rear Admiral Patrick Ocarroll. He is the Regional Health Administrator for Region 10, which is Alaska, Idaho, Oregon, and Washington. Of the U.S. Public Health Service. He's also been recently appointed as Senior Advisor to the Assistant Secretary of Health, Karen DeSalvo. He is an expert in health informatics and is he co-led the development of the nation's first training course and textbook in public health informatics. How I know him is I'm lucky at the University of Washington to see him in our region, and he is also on faculty there. We met, and he has great visionary ideas of how you can really improve the second decade of life, and how can the Public Health Service also partner, not just communities, but public health, researchers. How do we all partner together and really help communities figure out what they might want? I hope that he'll have a few minutes to kind of talk about some of that work. But that is really expanded, and I think he's a wonderful partner in all of these discussions. He's received numerous awards, including 2 Outstanding Service Medals, and he's a joy to work with. And thank you so much for coming.
So could I invite my panelists to come on up? Please join me up front here and take your seat. Let me begin by asking, first of all, thank you for that great introduction. Let me begin by asking the audience, and you can raise your hand multiple times here as I ask the questions. Who in this group is a researcher? Raise your hands, please. Wow, okay. Who in this group works to implement community programs? Great. So part of that was for me to get a sense, and part of it was to get you exercising after sitting for an hour. So if some of you want to do like warrior pose or Pilates or something to get yourself going, that's fine. And I mention that because it's very easy for us to get into the mode of talking at you. And as Jose said at the beginning, and we want to really demonstrate this with our first panel, what we're going to be about is teeing up the conversations. And as you saw just now, it seems like we never have enough time for conversations, but we take way too much time to tell you things. So we have committed as a panel to keep ourselves, each of us, to 7 minutes. I'm going to really abbreviate the introductions. I'll do rapid fire here in a few moments with your permission, just so that we can get started. And actually, I will be one of the presenters too. So that's 7 minutes times 5 already. That's a lot of listening. We'll save questions to the end. So for all of you my age, please take out a pen and make notes. For all of you younger than me, please take out your iPads and your iPhones. Make notes as well, because it's going to be easy to forget the questions you had for our second or third panelists, but you don't want to. So remember, this is all about where did we start to slip up when the rubber meets the road? From translating from research into practice, where are the lessons learned? What are the comments you want to make on what we did? What questions are you left with? But please focus on that application question, not on, can I hear more about your program? Because when I was getting to meet my panelists by phone, I could have listened to any one of them all day long with the really cool work that's going on. So it's really about the application and lessons learned and how to learn from their experience. Let me begin by running through very quickly who's on the panelists besides myself. There's Pastor Christopher Harris, who is the spiritual leader of Bright Star Church in his native Chicago, a noted gospel and jazz singer like myself. No, I'm just kidding. Pastor Harris has ministered and sung to over 20 countries and recorded on over 15 projects, and is also the founder of the Bright Star Community Outreach Project, and you'll hear more about that. Dr. Richard Spath is the F. Wendell Miller Senior Prevention Scientist and the Director of the Partnerships in Prevention Science Institute at Iowa State University, and he provides oversight for an interrelated set of projects addressing a range of research questions on prevention program engagement, program effectiveness, culturally competent programming, and dissemination of evidence-based programs through community-university partnerships. Dr. Gary Belkin is currently the Executive Deputy Commissioner of Mental Hygiene in the New York City Department of Health and Mental Hygiene, and was most recently the Medical Director for Behavioral Health in the Health and Hospitals Corporation of the City of New York, which operates incredibly 11 public hospitals in New York City. And finally, Commissioner Gladys Carrion has been recognized as a national leader in her efforts to reform the juvenile justice system in New York State and a fearless advocate for children and families involved in the child welfare system. She was appointed Commissioner for the New York City Administration for Children's Services in January 2014, where she is charged with providing child welfare, early childhood care, and juvenile justice services to the city's most vulnerable children and families. So join me in welcoming this august panel. I really appreciate it. It's an honor to be here with you. Thanks. So I'll begin, and just to be clear, my 7 minutes begins now. As Leslie mentioned, I've had the opportunity to work on something called the Second Decade Project in the Northwest, which we're now experimenting with around the country. Let me tee it up in this way. In my field of public health, we frequently get focused on something when it becomes an issue, going back to outbreaks of smallpox. If there's an outbreak, that focuses your mind, you work on the outbreak. And this is still very true. There may be a city, for example, in Cincinnati that decides that bullying is a major problem, and they institute a bullying prevention program. In Seattle, perhaps we've identified obesity as a major problem, and here's Nick in Seattle, and now there's an obesity program in Nick's schools to prevent obesity and to promote active living and good eating. And in Pamela, they've identified, in Pamela City of San Diego, they've focused on drug abuse, and they've got a bunch of programs teaching children the dangers of abusing drugs and where to get help and how to resist peer pressure and so forth. And so that's great, and that's typically how we work in public health. A community gets interested in something, or we get interested in something because of the mortality rates or because it's worse than it used to be, and we focus on that thing. The downside of that is that Jenny, for example, if we assumed all these were successful programs, may never have experienced bullying, but is now facing obesity at age 20 and is already being diagnosed with prediabetes. Nick was able to avoid obesity because of all that wonderful programming, but unfortunately took up smoking, which is the #1 cause of preventable death to this day in this country. And then Pamela, fortunately, was able to avoid the scourges of drug use, but did not have adequate sexual reproductive education, and through poor judgment on one evening, became pregnant, ended up dropping out of high school, and all of the social and economic and ultimately health implications of such an event happening in her life. And this is what I kind of noticed in my 31 years in public health, is that we have a lot of individual programs, but we don't really have an integrated way of helping communities put them all into effect. This is what I see as the problem, and particularly for the second decade. Because as you all know, because you work in this field, during those adolescent years, an enormous amount of health-promoting or health-damaging behaviors can become instituted and occur, but few communities do all that we can be doing to promote health. Now, I want to be clear, we have some terrific evidence-based programming in all of these areas. If producing evidence-based program documents and recommendations could create health, we'd be the healthiest nation on the third planet from the sun. We have all kinds of documents, and they're all really well researched, and they're all really well written. But from the community point of view, the challenge is somehow to take all of this and integrate it in a way that is comprehensive and yet still easy to absorb and use if you're not a professional researcher, but you care a great deal about your community. Our target leader then, for this project, was a community leader who is a champion in some ways for this decade, who either has already or can assemble a broad coalition of different people, of different cultures and different levels of expertise in a community that wants to do something about this. That's our sort of prototypical target user. Now, the way we did this was to interview a bunch of folks, a lot of community folks, to find out what they really needed. We also interviewed experts and a variety of others who have great depth in this field. But we really wanted to hear from people who tried to do these programs, from mayors, city parks directors, people like that, as well as parents. And what we learned, and these are sort of our lessons learned, was that the guidance had to be really simple to get going. It had to be action-oriented. This is a key point. It had to have multi-impact measures, so that it wasn't just doing something that just prevented smoking. It was doing something that had a lot of different protein manifestations that were healthy. And it couldn't just be a long list of separate programs, which is what I thought it would start out to be, that it would be 47 chapters, and if you just plowed through all 47, you'd be doing great. And so what we came up with was this second decade community guide. And again, my talk is not about the details of the guide, but rather about this process. What it's effectively about, we're trying to build here, is a kind of prevention architecture. So the foundation is that coalition I talked about. And the next step is a small number of multi-impact measures, like a school-based community health center that can do multiple things, or a program to develop parent engagement where you can prevent and promote a lot of, prevent problems and promote a lot of healthy behaviors by promoting parent-child communication and so forth. And then sometimes for specific high-impact areas like teen pregnancy or smoking or obesity, there'd be key issue-specific things to include as well. But this is where the community would choose for itself and model specifically what they wanted their plan to be. This is just a general framework that we saw community leaders using as a way to get them to develop their own prevention architecture. That's the idea of this integrated framework. That's our hope. Now, the example I'll run very quickly is to, if you think, well, what about smoking? That is important. Well, the foundation doesn't change. It's the coalition. That's part of the power of this. You have one group working on this. But those multi-impact measures, like a school-based health center, can have impacts on smoking as well as other things, teen pregnancy and bullying and violence and nutrition. But they can be a place where anti-tobacco messaging goes on and where people can be referred for cessation treatment and so forth. And then, of course, there would be something specific to tobacco if this was one of the things the Community Coalition wanted to focus on, like promoting excise taxes or ensuring there were cessation services in the community and so forth. So that's an example of how this could be applied to one issue. But the idea is this is not all about one issue. It's about a broad community plan to develop a place where, by its nature, it's easy for the community to work through and create a community that is going to be healthy for adolescents in this second decade, and it's going to be easier to grow up healthy than otherwise. So where we are today, and I know I went through that very quickly, is we're starting to work with communities to find out if this works. We've got 5 pilot tests all the way out into the Pacific and to the East Coast of the United States, trying this out. Now initially we're just trying it out to see if it's even usable. You know, we've just written it, we want to find out, can a community take this? Is it at the level it makes sense to them? And can they produce a plan within a year that has those multi-impact measures? Now, I want to stress that it still sometimes begins with a single problem. There may have been a drug overdose death, or there may have been a cluster of suicides in a school, and that's what gets the community motivated. But our hope is that through this planning process, it'll help them take a broader look at doing a variety of things that can help people in this age. So that's just one of the projects you're going to hear about today, and let me turn over now to Pastor Harris.